To begin with today's program, I have to thank Sanofi-Genzyme and Biogen for giving us the funding to do today's program. I hope that you all appreciate it as well. Let's give them a round of applause. We cannot do our programs. We cannot do our programs without funding from the pharmaceutical industry. Dr. Hunter has done a tremendous amount for the local MS community, and he's going to be doing that much more because we're going to get him to speak more and more around the country as well, and he's going to be video recorded many times. And so, we're expecting thousands of new patients and caregivers are going to be able to see him here today. And so let's welcome Dr. Hunter.
Okay, well, I got it. Great. So, thanks to Stuart, and I welcome everybody. I'm going to try to park that somewhere where it doesn't bother everybody. In case if you wonder what the purple bag was, this is my practical kit for people with MS. Now, it's just gotten cool enough here that you don't use it, but if you're not from the South, you need a fan, and it ties up in a little bag. And then for those people that got sore spots, we got you a hot pack or a cold pack or whatever you want to do with it. Either if you still do injections, you can do it if you have a sore back or neck. But that's from us at Advanced Neurosciences. I know a lot of your faces. Welcome. I'm happy to talk, and Stuart asked me to talk about a topic that I don't talk about a lot, which is how to communicate with your doctor and get your best MS care. And I think it helps to understand what we're dealing with MS. And so this presentation is about how to organize your information. You have a very short time to get the communication across, and getting that together is really important. And some MS patients learn to do that well, and they get much better care because of that, and some don't. And there's challenges. Everywhere in the world has a challenge. In the United States, people with MS actually have it better than just about anywhere because they have a lot of physicians who want to help. They have a lot of resources from industry and from insurers. Believe it or not, those big bean insurance companies, they care about MS because they spend more money on MS than just about any other disease. Well, you would think all those people with cancer get more money spent on them. Well, yeah, but a lot of them don't make it. And the people with MS are going to make it. You're going to live. You're a problem. You want to get yourself the best care that you can for the best outcomes that you can. So we're going to talk about that, and I'm going to try to give you an understanding of how to do that and how this ties in with the process that's MS and what you feel and you see and other people see and what limits you and how you live your life and how to get those things organized and to be able to manage yourself proactively. And this isn't easy to do. It's not easy to raise a child. It's not easy to have marriage or run a business, build a house, but this is what you got to take the approach with your MS that you're going to be able to do this. And I always tell people with MS, their problems are all in their head, but it's not their imagination. And that's it's helpful to add a little humor to the never-ending list of things that MS seems to give you and cause you. And people always ask me what's due to MS, and I always tell them it's not a genetic disease, despite all the things you hear about genes. The risk is genetic. But not the disease. And it's mostly that people with MS are genetically wired to have low vitamin Ds. Not everybody, but most. It's mostly not a virus, but there's a virus that everybody has called EB. We can't prevent that right now. Someday we will have a vaccine that prevents that. It's the same virus that causes mono, but most people don't get mono who have MS, and vice versa. Most people who have MS didn't get mono, but mono is a marker for an immune system that's of the type that can get MS. So this EB virus, there's no sense in going out and getting tested for it because every one of you have it, 100% do. And 90% of everybody else has it. It's not mercury. If your dentist starts salivating when he sees mercury in your teeth, it's not going to help you to get it out. If it's broken, fix it. Otherwise, don't. It's despite what's been circulating on the net for 20 years. It's not aspartame, and it's not toxic mold, especially those people who live in humid places. It's not celiac disease, and it's not food allergies, and it's not what you ate. Being overweight is actually a little bit of a risk, and it's not animal exposures. Back when I was going to medical school, we all thought dogs caused MS. Aren't we glad that they don't? When I was in medical school, they also thought a wild lifestyle was bad MS. And I assure you, it's not because you were a bad girl sometime. It's because of bad luck, and that's why you get MS. It's the right factors and the immune system, which we share with almost all animals, all the way back down the development tree to sharks, basically can make mistakes. And once it does, we come out and we have an immune system that's primed to go after things in the people who have MS and who have other immune diseases. They all share this kind of immune system. If you have thyroid disease or psoriasis or one of these common problems, you're possible to get one of the less common problems like MS or rheumatoid arthritis, Crohn's disease, that are all the same setup. So the bad luck, once it starts, it doesn't stop. Most of what happens to you, you really don't notice it. It's going on all the time. And the low vitamin D is the most important thing because it sets you up to get it, and it also is a way to control the disease. 50% of the disease can be made better by getting adequate vitamin D year-round. Tobacco is a huge negative factor, and unfortunately, we didn't understand this until just fairly recently in the scope of things, just how harmful it was. Even exposure to tobacco smoke indirectly in your environment is a powerful drug for the worse. Salty food may have an effect, but salt's not that great for you anyway. It turns out that, for those of you who are women and have two X chromosomes, which I assume is most of them, it's the two X chromosomes in part. One X chromosome doesn't seem to be as bad, but it's the X chromosome is important in the function of the immune system. And we talked about our friend EB virus, which someday we may have a vaccine before, but they've developed vaccines before and they didn't work. And then there's this genetic risk, and the genetic risk is over 100 genes. And the best as I can figure it, people ask me, why do we have genes that give MS? And those genes are there for a reason. They were good for something, and they were probably good for Northern European people because that's where they mostly came from. And they help prevent a lot of diseases, and they basically keep the immune system turned on. So dealing with TB and things, when people only lived to be 30 years old, those things were really important. And once we got sewers and got rid of the worms and had antibiotics, now we have a problem because we have an immune system that doesn't know how to slow down. All right. So what happens to you when you have MS? Most of you feel abnormal. Some feel fine. It's a small group of people. They're usually in milder disease or they're earlier in the course, but most feel, my head isn't right. Something's wrong. My head is foggy. I can't concentrate. You may have some strange sensations or pains. You may feel clumsy. You usually have some kind of limitation somewhere in your vision or your walking or your bladder or your energy. And these vary all over the map. And MS ranges from a very benign illness to a very malignant one. And we'll talk a little bit about that later, because not only do we have to talk about MS and how bad you are now, but how quickly you're getting worse. And people have mood problems with MS. Many of them feel worthless, and the overlap between depression and MS symptoms is huge. In fact, it's a good way to assess how people are doing, in part, by just asking them how they feel. Because if it's the mood, it's important, and if it's not the mood, it's important. And we know some of our medicines make mood worse, and some of them make them better. And actually, medicines for mood actually make MS better. So it's an important part of how things work. And about half of your brain in the front is where you live, and the other half is how you process information, and the lower half is the input-output system. And so the symptoms that are real MS specific are the input-output system, and the parts that affect the rest of the brain mainly affect your thinking. All right. Now, I'm going to tell you how neurologists think about you. Okay, and most of your neurologists, you are experienced consumers of healthcare generally if you've had MS, and some neurologists are better than others at MS. So I'm going to tell you why you have problems, because MS is tough for neurologists. It's time-consuming. They look at MS patients as forgetful. They look at them as slow. And when you're not doing well, you often think about half the speed of a normal person. For somebody who's trying to get the job done and get information out of you, this is noticeable. It's trouble to diagnose MS. It's time consuming. It's been made worse by the fact that now we have much more access to MRI scans, and we've realized there's a lot of people out there who look like they have MS on MRI scans. About 3% of everyone looks like they have MS on an MRI, but only about half that many people will actually have the illness that's noticeable. If you go to family members, if you take MRIs of family members of people with MS, 10% of them do it. If you have a twin, half of them do, even without having MS. Many of those people go on to develop MS. It's trouble to diagnose. It takes more time for a neurologist than any other problem we have. Why is that? Because there are so many issues with you. And so a lot of neurologists wish somebody else would do it. And they may convey that verbally or non-verbally to you in the way they act. And they despair in that it's hard to make people with MS happy, because okay, you had a big pain, we got your pain, you come back, you're not talking about the pain anymore, now you're talking about the fatigue, and we get the fatigue treated, and you come back and you're talking about your bladder. Yes, we want to do that, and unless you have a doctor and a team in many cases of doctors that's going to address all your problems, you get very frustrated, and the doctor get frustrated. It takes a long time to do this by talking. So we're going to talk about strategies for how you make your communication more effective. And neurologists even complain to me. They say, "I just don't want to bother with these medicines. It's so hard to get them approved." And there's a lot of behind the scenes work. But just so you understand why you have a hard time getting things done, basically, being in the physician's office is the most important way to get things done. And you will not get nearly as much done outside of a physician's office, no matter how hard you try. So, if you're new to MS, this is going to be all new to you. If you're not, you may find it a refreshing perspective. But I look at MS in several dimensions. The first is the symptoms. They're what you notice. But there's a disease process that's going on that's what's in your body. And this in your body is important because we have to pay attention to it, even when you don't notice it. You may notice it. There are social consequences. You have to live your life. You have to work. You have family. You have to maintain your relationships, and all these things are affected by this disease and the symptoms. So recently, on social media, I've had some of my patients go to calling MS an invisible disease, and I'm like, I'm doing a good job if it's invisible. But some of the symptoms that are invisible actually don't indicate how bad your disease are, but they're a big problem. They don't even show up on our rating scales in some cases. But fatigue, for example, which is the biggest complaint of MS patients by far statistically, usually doesn't indicate how bad the disease is. It can be associated with bad disease, but you can have severe fatigue. Sensation problems, pins and needles, numbness and tingling, shooting, pain. These things don't indicate how bad the disease is. They just indicate that the nervous system isn't functioning right. And even pain, which you're wired to believe is a really important problem, has nothing to do with how bad it is. It does, however, motivate people to go to the doctor, but it's hard to learn to deal with a pain that doesn't go away. That takes years for most MS patients to come to grips with and how to deal with that, but they do. Mood problems don't indicate the severity in most cases. Dizziness, which can be a real problem, vertigo, the turning sensation, queasy, nauseated, head floating, feel like my head's not put on right. That actually is a very minor disturbance in the nervous system. It just has a big effect. But there are some things that people can't see that do indicate the severity. And if I can get the Thinking is a problem that's very important. Thinking is often MS because it affects many parts of the brain, and the communication between the different parts of the brain is important. Your bladder is an invisible problem to a lot of people, and it really does indicate more severe difficulties with MS. But there are things that you see and the doctor sees: your vision, your balance, your strength, your gait, a tremor. Tremor is really only important if it's severe. Minor tremors don't mean very much. My most common thing is to send people to Walmart to buy wrist weights because it stabilizes their hands and gives them some inertia. And then while you may notice problems with your speech, when we say speech in medicine, we mean whether your speech is slurred, whether it's hard to understand you. The word finding thing is much more your effort, and other people don't really notice that most of the time, unless you're really having trouble and you choose the wrong word. So it's really many different problems. It's one illness. And, you have to deal with all these things. As a neurologist who treats a lot of MS, I deal with all of them. I get help from a lot of other people to do it. I may get help from a therapist if somebody's really having walking or occupational problems. I get help from a psychologist if they're having mood problems. I get help from a neurologist if the bladder problem is more than a simple one. I give a lot of advice. A lot of the simple things I just give advice about because it's not worth you spending a lot of time and money. If you'll listen to my advice and do it, will usually get done. Vision is really important. Eye doctors are really important to help you see your best. Some are better than others. Some are way, way, way better than others. I do a lot of eye assessment. If it's behind the eye, I don't fit glasses, but I try to figure out how much it's affected. Why? Because it's important for the MS, and we deal with people who have no eye problems in some cases, a minority of MS patients. Nearly everybody has some, and some have them really severely, and they require major rehabilitation. So what's going on in MS? Immune dysfunction, and you don't notice that. You don't appreciate that, except maybe around the time you get an infection that everything gets worse. There are visible lesions that we can see when we're examining you or on an MRI, and there are invisible lesions, which are neurochemical lesions or microscopic. On MRI, we can see you have a brain atrophy. We can see you have acute and chronic inflammation. And we can see that there's an effect we call axonal degeneration, which is associated with the brain atrophy, which is a loss of nerve fibers. Everybody loses nerve tissue normally, all right? But people with MS lose it much faster, 5 to 10 times as fast as everybody else. And so that adds up over time. That's one of the reasons for the priority with getting MS treated and staying on treatment. So this last week, our very first medicine went completely generic with MS. It's amazing. It's a new era. It's wonderful. It'll be a while till it's cheap. And we'll see. So these are the players. These are what are causing your problems. These are certain cells in the immune system that are tasked normally with taking out the garbage in our bodies and recognizing who's not supposed to be there and policing it. Get rid of tumors before they're big, deal with viruses, deal with parasites, and these cells can make mistakes. They're beautifully designed. They're little tiny machines. They're just a little bigger than a red blood cell. Those little faint donuts are your red blood cells. They float around in your bloodstream when they're moving. They use the bloodstream as their train tracks to move around the body in part. And lymphocytes are basically designed to go and kill things, and that's how they do it. They actually kill cells that are infected or not behaving properly, and they kill foreign cells. And these are activated, and they make copies of themselves. And if you've ever seen the delightful Disney cartoon called The Sorcerer's Apprentice with Mickey Mouse, who bewitches a mop and a bucket to carry water for him, and then he can't make it stop. This is very much what goes on in autoimmune diseases. They're started in a well-meaning fashion by the immune system responding to commands and directions, and then they get out of control, and you can't stop them. And these cells, we have lots of medicines that push them around, that make them oblivious to what's happening, so they'll leave the immune system alone, or ones that even just eradicate them, a lot like using agricultural chemicals, just to wipe it all out and let it grow back so we can get it under control. So all these disease factors in MS are a factor. The lymphocytes are causing the problem. The aggressive lymphocytes actually cause MS. They start out here in your lymph nodes. They're born, they come to the lymph node, and lymph nodes are kind of where the orders are passed out in the immune system. That cells serve up little molecules that they see floating around to the immune system. And if the cell responds to it, it makes copies of itself, and it starts dividing. And it divides about twice a day. So within a week, you have 1,000 cells with that. And they get in the track, they leave the lymph node, and they head out into the circulation. They look for blood vessels that carry markers that say there's something wrong here. And that's where they enter the nervous system, and they go in there, and if they see that target, they go and kill it. And this is what causes immune disease. If it's your thyroid, the immune system is usually so good at it, it just erases it. It just stops working altogether. Well, fortunately, we can replace thyroid hormone. Unfortunately for the cows it comes from, but we can replace thyroid hormone, and you live a normal life. But these aggressive lymphocytes, when they're targeted for a particular organ, will keep going back there, because the amazing thing is they come out of the brain too, and they head back to keep the process going. And we've learned about that just recently. One of my colleagues at the NIH has been able to show that what we used to think were blood vessels, that we see blood vessels here, we can also see there are little tiny lymphatic channels in the brain. This is the drain system for the brain, for the cells. The immune system also has these cells come out, and they go back to the lymph nodes, and they keep it going. And so some of our mechanisms work on the cells coming out, some of them work on the cells going in, some of them just make the cells hard to do their job, or some of them just erase cells. So all these things are really fascinating, and we're just now getting our hands around what's going on in MS. So what is MS? It's immune disease. The cells are going in there. What we call sclerosis is a scar that's caused by these attacks, and it resembles a lot acne. It's a reaction of immune cells to chemicals, and they just happen to be your own chemicals in this case. In acne, they're bacterial chemicals, and it can cause almost any symptom, and it's principally the connections are involved between the nervous system. All right. So when we have nice MRI pictures, this is great. Anybody look around the room and say, I can see that across the room. Okay, that's a patient with MS. Okay, they've had it a while. The problem is it doesn't start out looking like that. About 20 to 30% of people, when they go to the doctor the first time with MS, their MRI is normal. Yeah, or it's read as normal. It may not be completely normal, but it's underwhelming. Let's put it that way. And sometimes you have the misfortune to have a bad day with whoever looks at your MRI, and they put some kind of report on it that the doctor who actually sees the pictures next falls out of the chair when he reads the report, because it's nothing like what the picture shows. So things can go wrong in medicine, and MRI scans are a frequent one, because it takes a lot of technology to get it done right and a lot of technology to interpret it right. So the bad spots are called black holes. These are more severe areas of inflammation where it's almost erased the brain. So on a microscopic level, it's a little bit different. And what you've got is information that has to move through the nervous system. The longest pathway is from the crown of your head to the middle of your back. And that's a tiny nerve cell that runs that way. And there are many thousands of them that do every task. And if you have some damage, that a little bit, and it's not in that pathway, it gets through. People feel normal. Things work right. But if you get enough damage, it doesn't really make it, or it doesn't make it reliably. This, if we looked at this on a single cell level, when you lose that, when you lose that area of insulation, the information doesn't move as quick. That doesn't really matter. It can move very slowly, and it's fine. What matters is that when you try to use it a lot, it stops working, or it doesn't work at all. If you get that body temperature up there, well, you're one big chemical reaction, and those chemical-based systems for transmitting those impulses, they stop working. What's even more unpleasant is sometimes they work on their own. When you bend your neck, it goes off, or when you may feel a shock down an arm or a leg, you may get a spasm where a limb will contort or get into a position, and those are due to these same areas. So if you go even closer, we have mechanisms where the little tiny nerve fiber is metabolically trying to maintain and do this to generate energy from mitochondria, and just like you racing your engine really hard wears it out, that happens with these nerve fibers too. So there are ways to protect nerve fibers. There are ways to make them work better. The first thing is try to get the inflammation out of there, because the inflammation basically sucks all the oxygen out of the nerve fiber, and it's in a very similar way to a stroke-like condition. It's barely hanging on because it can barely get enough energy to do its job. And if you get too much rundown, if the nerve fiber can't handle the amount of information that's going through it that lets in sodium and calcium, then it just won't function at all, or it will degenerate and die. So this is a loop of what goes on inside the brain without treatment and in people with MS. And these flash bulbs going off are areas of inflammation that come and go over many weeks. This is why we don't always see something on MRI, that the little tiny ones there, the really faint ones, these are things in the past that have been repaired in part, and there's a little residual there. But the big areas of inflammation where it come and go. See why I told you it's like acne? It's a lot like acne. There are big ones, there are little ones, there are bad ones, there are old ones. It's all adding up together. And that scarring is caused by the more severe ones, but the inflammation is completely preventable almost by our MS medications. And most of what our medicines do is stop the new lesions. The old ones, the damage that's already there, they have the opportunity to repair on their own. But we've also have this element of our brain that's not the connections, that's the gray matter, where our thinking is. And that is affected too. And that happens on a microscopic level. We can't see that on MRI. So your brain has, between every nerve cell, thousands and thousands of connections. Every one of these little tiny spines is one connection from another nerve cell talking to that. That's what makes our miraculous brain work, our computer, our processing. That's what we can't reproduce in a machine. This untold billions of connections. And what happens when we get inflammation is those connections disappear. They disappear very fast. Where did they go? Well, the immune system ate them. Okay? And it's not the immune cells that come in, it's the ones that are sitting there. Their actual normal job is to keep things tidy. And when there's inflammatory signals, they start destroying the connections because they're trying to get more aggressive to get ready for whatever's coming. This happens in Alzheimer's disease. These connections are eaten up. If I put this picture up and say this is somebody with Alzheimer's disease, all the doctors will say, yeah, that's what it looks like. You've lost these connections between different parts because the immune system is activated. It's the innate immune system, what we call the microglia. They're stressed by lots of things. They're stressed by a hit on the head. They're stressed by diabetes. They're stressed by high blood pressure. All these things they're stressed by, but they're especially stressed by inflammation. And we even have one MS medicine that protects against it that's out there, fingolimod. And fingolimod actually protects these connections. And so there's a lot of benefits to treatment, and you don't see them all on brain scans. There are things that are worse when there's inflammation, there's demyelination. We talked about there's a lot of oxidative stress, which is from the inflammatory cells. And when cells turn on, it damages things. That's part of how they kill stuff. And then the axons, the nerve fibers cannot quickly compensate, and some of them will actually get broken in half by the inflammation. In the long term, though, repair doesn't always happen, and the axons don't have enough energy, and they're more vulnerable to degenerating. So people always ask me about myelin repair. And guess what? You're already doing it. You're already doing it. We'd like to do it better. It doesn't always complete, but we've known forever that this happens. And this is someone's brain, some kind person who donated their brain to science after they died. I always ask people to donate their brain to science while they're still alive. That's called research. Okay, but this is someone who donated their brain, and this blue part is the white matter. This other part around it is gray matter, and these big zones are areas where there's been MS plaques. We call them plaques because the immune cells come out of the blood vessel and they invade the brain and damage it. And these are demyelinated areas, but there are lots of repaired areas here in this person. In fact, this is an MS plaque. This is an MS plaque. This is an MS plaque. They're repaired, and this one is in the process of being repaired. Gradually, you can see the cells advancing in from the edges. This one is mostly not, but there's a little bit right there where it's come in. And we don't understand all the reasons why things don't repair, but mostly it's because the damage is just so severe, there's not much there to repair. But if the inflammation is still there, it won't repair. So the most important thing is to keep it small, keep it from happening again, and not get in the way of it repairing, which is letting the inflammation go on. So these cells, these little delicate cells that do this repair and make this, we understand them. There are hundreds of them sitting around these lesions waiting to repair. They just won't do it if there's still inflammation there. And they come from a stem cell progenitor of the brain, and these cells, there's a lot of them here waiting to do that. We just are now starting to find ways to encourage them to do that. But the best way to encourage them is to stop the inflammation. And we see people whose MRIs get better. It looks like this on an MRI. You have normal area. You have an area that's not normal, but it's much better than the area in the middle. This is a lesion that's repairing like this. It's a lesion that would look like this. And then, when you get repair, everything works right again through that area. And it's the best thing you can do. It improves the energy. But there's a lot of things that are going on in that inflammation to impair the ability to produce energy. Not only does it make it require more energy to function when it's damaged, but the inflammatory cells actually hurt the energy production. So this is why people can get better with MS. This is why there are relapses. This is why when people go on some therapies in the long term, you see them get better. And you see them get better for years and years, getting better and better. I call it secondary regressive MS. And if you hear that, it's mine. I patented it. Okay. All right. So anyhow, stop the inflammation, keep the lesions small, improve the function. We have some medicines that improve function. There's a medicine that's been marketed for a number of years called Impera. It works for some people. It makes the axon easier to work. It needs less energy. Some of our other medicines, some of our stimulants actually make people work better. Why? Because it takes the brakes off. It takes the brakes off. And we tested one last year called amantadine that a lot of people have had. Amantadine made everybody walk 25% faster like that. It was impressive. So even a tiny amount of myelin makes everything function better. In these areas of the brain, they may not even show up on an MRI scan. They're so much better. And we do see lesions go away. The average person, when we put them on therapy, 10% gets better. So they aren't damaged so badly that they can go away. I have some people that over years with effective treatment, we see it get better and better and better. Something that's a burned out old black hole, that's not going to go away. That's just a hole in the brain. So we have medicines that do something to everything good in the brain. And we normally think this is a medicine that's known because it keeps immune cells out of the brain, traps them in the lymph nodes. But it actually works on all the cells in the brain. It calms down the inflammatory cells. It makes the nerve cells and the glia happy. And it helps prevent your synapses from getting eradicated. So people think about, they're very focused on certain MS symptoms like fatigue, or pain, and they say, this medicine's not working for me, this medicine's not working for me. But many times these medicines are working very well on everything else in your brain. And so you treat symptoms differently than you do the disease. This is an example showing that function, this is measuring the speed through the eye nerve. This is called VEP, that the people who are getting better, their speed improves. And we know we can do that. We know that happens with our current treatments. There's not anything yet that we can repair things reliably with other than treating people effectively with good medicines for MS. All right. So what goes wrong with you when you have MS? Your occupation. It's number one thing. People can look normal to everybody else and not be able to do their occupation anymore, whether it's physical or mental or both. Physically, they may not have the endurance to do it. They may not, if they have to walk or they have to climb or balance, they may not be able to concentrate with the vision. It may take too much work to look at a computer or a spreadsheet, or to be able to hold all that information in your head at once to make the decisions that you're required to do in employment. Interacting with others is often a big difficulty in the family. Seeing a divorce is almost routine in people with MS. It's very stressful on a family when someone's ill for any reason, no matter what the reason is, much less with the impairments that people with MS often have. And then the financial cost of being ill, even with assistance for medicine and things, is small. And I always joke with people. They always tell me, "Well, I don't want to pay for another visit." And I'm like, well, we're not going to get things done if you don't come back. We're not going to be able to do it. And I said, your hair looks pretty nice today. How much did that cost you? Yeah. Let's just try to put it in perspective. All right. So how do you get good care? Let's come around and talk about that. So you get your data together. All right. And the biggest thing I have a problem with is we've got a limited amount of time, and I take more time than just about anybody, but it's limited. And if it takes 10 minutes for you to give me your medication list, then that's 10 minutes we didn't have. Okay. And if you write down the same as last time, I have to go through and I have to check, is it the same as last time? Because almost always when I check, you've got it wrong. So if you do that, it's really important. Your data. Where have you been? When were you there? You were in the hospital. When were you in the hospital? What did they tell you? Where is the data? Everything that happens, we've got to know about it. We've got to know what happened, why it happened. Was it something we did? Did it change something? You had labs. Did you bring the labs? Did you have the labs sent? Don't assume anything happens unless you make it happen, because it won't in medicine. It just won't. You need regular visits, and you have to follow through on the plan. If the doctor gives you a piece of paper and says, do this, you need to do that. Or otherwise, the first thing I'm asking when you come back is, okay, how did it go with that? Well, I never did that. Well, guess what the plan is this time? Is to do what you didn't do last time. You got to, if you want to make progress, if you want to get things solved, you have to collaborate with the physician. All right. If your doctor ever says to you, just come back if you have a problem someday, get another doctor. Okay. That's not how you manage MS. You don't do that. If you have a new problem and you need to be seen right away, yeah, you need to come back. But if you aren't having regular visits to assess how things are going, whether something's going wrong, you're in the wrong mode of care. Do you know how long people get in Great Britain with a neurologist when they see the neurologist? Anybody want to guess? Anybody heard me tell you before? 3 minutes. 3 minutes. If you're really sick, you can ask for a double visit. 6 minutes, okay? In Germany, they're much more generous. You get 7 minutes. 7 minutes. In Italy, you get 5 minutes. I asked my Italian colleague, how do you take care of somebody with MS in 5 minutes? He said, I don't let them sit down. That's actually a good solution, but you might get a little more done in 5 minutes. In Canada, it's 5 minutes. So the whole point of seeing someone for MS is to assess how they're doing, make sure they're safe, get them a plan for how to deal with some things, and you're at most you're going to be able to deal with 2 symptoms, maybe just 1. And if there's anything important that's come up, it's going to take over the whole visit. So if your plan is that I only want to see the doctor, twice a year and talk for an hour and a half, it's not going to happen, because you've got to have it broken down into chunks, and you got to work on it in periods of time that can be done in the office. And if your doctor says, come back and see me just once a year, and you call them and say, I'm having a problem, they see it's still a year away. There are actually big institutions who tell people 3 years. And it's like, I'm like, go somewhere else. You got to get better care than that. You're not going to get anywhere with your MS. All right, MRIs. MRIs have to be done according to a certain technique. If your place says, oh yeah, we do all the MS patients, and you ask them, do you follow the CMSC protocol, which is the internationally agreed upon protocol, they'll say, what's that? What's that? It's been there for 15 years. You're supposed to be using it. Most places, when they do an MRI, and it's about 90% of places will not do it adequately, 90%, and they'll skip at least 20% of your brain, and they will do the MRIs in a way where you can't see anything bigger than 4 millimeters or smaller than 4 millimeters. And if you do that, you won't know how your MS is doing. And they'll say, everything looks the same, and it could have changed 3 or 4 millimeters, which is a big deal. For you. And if they don't look at it carefully and they don't do a comparison, if you don't take that compare with you to the MRI, to be read, it's not going to get done. They're not going to do it, and they'll charge you just as much. They'll charge you just as much to do a bad job as they will to do a good job. You have to take control and make sure it gets done right. All right. So do's and don'ts. Do have your medicines. Do have a list of symptoms and what's the most important problem, because you're not going to get through them all in a visit if you have a bunch of them. Know when you've had problems. You should have a history of your MS, when you had a problem, what it was, how it affected you, what they did about it, okay? And if you don't have that and your doctor doesn't have that, you're starting from 0 every time you walk in the door, and you'll get just about as far. The dates and the kind of relapses. Okay, my left leg was weak. They gave me steroids. When was that? Look at the spouse. That's 2 minutes that have gone by. If you had that on a list, it would have been easy, and we need to know that. We need to know that when we're assessing, when somebody wants me to say, what do I do about my MS? I have to have data. I have to have it all in front of me, and I have to have it all at once. Otherwise, I'm guessing, and you don't want me guessing. So if you had thresholds you crossed when you started using a cane, when you started using a wheelchair, when you couldn't work 40 hours a week, show up with your glasses. It's a really good idea if somebody wants to know what your vision is. And so see the eye doctor before. Don't come with the old glasses. If I had to worry about whether your vision is adequate and whether the eye issue is part of your MS, then we're wasting time if it's fine and it was just that you didn't have your glasses. So bring your forms with you. If you want accurately filled out disability forms, then you be in the office with them at the same time. If you don't do that and there's a mistake made, it's very hard to correct. All right. Don't go to a doctor. And I tell you, I'm very tolerant of people. I know it's very frustrating. But if you are demanding with the doctor staff or with any physician and you go in there and you say, I want you to fix my pain, they'll show you the door. They'll write on your chart, pain medicine seeking, and that will go in your medical record, and you'll never get any help again from anybody. If you do that in a hospital, the whole hospital system will do that to you. You describe what's going on, you don't demand, because they deal every day with drug addicts, and they deal with 20 people who come in the door who are seeking drugs, and that's what they say. And if you say that, you will get labeled like that, all right? And realize that your doctor has two responsibilities. One is to treat you, and the other is that he doesn't hurt you, okay? And if you ask for something that he doesn't consider safe to do, and you start arguing about it, there's going to be a problem. He's going to say, I can't help you. And you stop the conversation about how to help you if you really get demanding. So don't try to make a neurologist your primary care. Don't go in there and say, I have an earache, treat this, fill my cholesterol medicine. I want my blood pressure refilled. They may tell you what to do, but you got to divide the labor between the people who are involved with that. And because this is your chance to get your MS taken care of. If you go in there and you've got him worrying about things that the urologist does, or your male function, or your menstrual cramps, or your hot flashes, you're taking away from the expertise that's going to be applied to that. You have to divide the labor to appropriate people. If you have a serious mood problem, get help from a psychiatrist. Get a real person focused on that, because everybody else is amateurs. If that's the biggest problem in your life, don't try to shy away from getting a professional who knows how to deal with that involved, rather than trying to get your primary care or your neurologist to do it. You can't get everything done at once, and it's not going to help you get any better care talking about what other people did wrong. And we all know that it's frustrating to be sick, and when you have an unproductive visit with another physician, it's regrettable, but it's not going to help you for us to hear about it at length. All right, so your time is a premium in the visit. Be organized and prepared. Know your medications. Know when you were at doctors, what exactly happened. Have the records with you. Don't assume anyone sends them anywhere. Have a record of relapses and treatment. If your blood pressure or blood sugar have been out of control and that's not being addressed, it's going to take away a lot from your neurologic issues while we're trying to be sure that somebody's dealing with it, because every physician is required to look after your safety. And ask your neurologist to do your EDSS score. If they say that they don't know how to do this, you need another neurologist. Okay, because this is the standard way to monitor disability in MS, and every physician who's experienced at treating MS knows how to do an EDSS score. All right, how do you measure yourself? Okay, this is important. Pay attention, because you can monitor how you were doing. There is a free program called CogniFit that Bayer Healthcare sponsors on the multiplesclerosis.com website. You go to multiplesclerosis.com. You normally have to pay for this service, but if you go through multiplesclerosis.com, you have MS, it's free. You can monitor how you do on some of the tasks that they have, which are like video games. They're similar to that. They're online computer tasks. Walking. How far can you walk before you have to rest? And 500 yards, 500 meters is about a third of a mile. That's how far I walk somebody in the office when I'm trying to precisely measure it. But you want to know how far you can walk, because that's a big part of how you're doing. You can also, over a shorter distance, what's 25 feet, time your walk. Just walking as quick as you safely can, 25 feet. You can use that trusty cell phone Mr. Siegel was telling you about. It has a timer on it, a stopwatch on it, to do that. If you do it less than 8 seconds, you're doing pretty well. The 9-hole peg test is a great way to measure your upper extremity function. From this place, clinicspeak.com, one of my colleagues in Europe, one of the most brilliant doctors in the world, developed a cardboard 9-hole peg test. You can buy it for $15 online, and the instructions come with it. It shows you how to do it. It's just moving pegs, and with a stopwatch, you measure how quick you do that. It's a very reliable way to tell how you're doing with your hands. You can videotape tremors. People always come to me and say, I have a tremor, and I look and they don't have the tremor. I'm just, get your phone out and videotape it. Have somebody videotape it when you're having trouble so we can see what it is, because different kinds of tremors are treated differently. Your strength. You guys who go to the gym, there's numbers on those machines. Figure out how much it is that you're able to do and how long. You can keep track of it yourself. The doctor doesn't need to know about it, but it helps you know what you're able to do when things are off. And your overall disability, we're going to talk about a little thing here called the patient-derived disability steps. It's a lot like the EDSS, which the neurologists use to measure MS, but the patient-derived disability steps are there. There's some other cognitive tests that we do in the office when we're concerned about this that actually you can do in about 90 seconds. It's a task called SDMT. There's not available to do that online. So what am I trying to do? I'm trying to control the progression of disease. I measure your disability. I measure your relapses. I look at your MRIs. These are the things. This is not your symptoms. These are my treatment outcomes. I try to make your symptoms feel better. Some of them we make go away. Some of them we can make better. Some of them we have to work around. All right. There are some treatments that are better than others. People don't get a clear picture because we live in a country where there is censorship of scientific information by the federal regulators. And this is for good reasons and for bad reasons. It's because of overbearing government bureaucrats who basically tell companies they can't tell you whatever they want. They can only tell you what the government is going to approve. So you don't get all the information about how medicines work. Every one of our medicines, there are 100 times as much information as what you are allowed to be told by government in a pharmaceutical industry sponsored thing or on a piece of paper or by their nurse. And this is really important that you get this information from your physician or from other sources about things. And this is an example. Okay, this is a medicine that's on the market for MS. It's not used very much because it's complicated to use and you have to be experienced to use it. But the people who get standard MS treatment get worse. The people who get this medicine get better and they stay better. And this is the difference between how people do. Not all of our medicines are equal, and people who are in certain circumstances need to be looking at different medicines. All right, so let's talk about the patient disability steps. Why is this important? Well, if I tell you, a 5 means you're walking pretty poorly with a cane. That doesn't mean very much, but a 5 after 5 years means a lot, okay? A 5 after 45 years, that's not so bad, So where are you? Everybody with MS in this room is going to look at this or this and tell me where they are. Okay, it's a pretty easy way to break you down. 9 steps. It would be 10 if this was a pine box. If there was a number 9 that was a pine box. Okay, all right. So there are people who have just symptoms and really don't have any limitations, and there are people who have small effects. There are people who have effects on gait, but they do a lot. There are people who have limitations where they have to do something to walk, and there are people who don't walk well, and people who don't walk at all. Basically. All right. So you got yourself? Did you see yourself on this? Everybody with MS, remember what number you were. Okay. So this is the big banana. This is where you fall in the universe of MS. So if you are a 3, how long have you had MS? All right. If you've had MS for 10 years, your number is a 3.6. That's the 36th percentile on the good side of average. All right? If you are in a wheelchair after 5 years, you're way out here. You're like the 95th percentile of MS. You're really bad. All right? So what we want to see is people getting better or staying stable in these disabilities, and because then your future is improving. And this is out to 45 years. And these, I'll try to put this up online where people can get it and look it up themselves. Now, this is the scale I use. This is the EDSS scale. It's got more steps. It's a little more resolution. This is why we say your doctor should know how to do an EDSS. And so a 3.5 is somebody who's got moderate disability with MS. And if I see a person the first year who's out there, that's the 80th percentile for MS. Those people are doing terrible. Most people with MS, you can't even tell they have MS for the first 5 years. I mean, they may feel a little numb or a little weak. So what can happen when we treat people? The first thing is, they can be on a very ineffective treatment, and they can follow the natural history for MS. And this is that person's natural history. This is walking slower and slower. In a few years, their limitations go from walking a third of a mile to walking a couple hundred feet, and then a cane, and then a walker, and then a wheelchair, and then barely able to walk, all right? That's what happens to that person in under 15 years, normally, on average. If they go on a treatment which works some, they're still worse, but they're a whole lot less worse than they were going to be. And if they're on a really good treatment, they actually get better. They actually improve. And this improvement in disability is what what pharmaceutical companies are not allowed to tell you about. The government will not let them tell you how many people got better. And there are treatments we have that actually make people better. You are not told about that. You have to look for that information. All right. So I do some of these things to measure cognition. We have a couple tests we do. One of them here, PACEAP, brings people to tears, where they have to add numbers that they're hearing on a tape. We can measure eyes by looking at really washed out visual fields, because people with MS can't see these letters as well as they can a standard eye chart. And here's the 9-hole peg test. This is what you can get for $15 and do yourself. One of the really revolutionary concepts in MS is that everything works for progressive MS. And I'm not allowed to say this if I'm speaking for a pharmaceutical company. But the fact is, because of the damage in the nervous system, people keep getting worse even though they're on treatment, but it changes down the road. And this is an example from a study that was done where this was drawn from. Everybody's getting worse. They go on treatment here, but the treatment seems to make no difference over a couple years. But then all of a sudden, the people who are getting treated now didn't get as worse as everybody else. But unfortunately, they decided that the treatment wasn't doing anything, so they stopped it, so then they get worse faster. But they're better off than the other group that got treated. And this has to do with the damage that's on a molecular level in these nerve cells. They're so stressed out that if you don't get the stress off them, they're going to die anyway. And it takes a long time. Once you get the stress off the cells, it takes years for them to be able to see the difference as an individual. And we can see it most commonly with the hands. That's why you see this moniker, think hand, because we can see it in every study when you look at hands. Now, this is brain atrophy. This is what happens over years when people aren't being treated. And unfortunately, a lot of doctors try to convince people not to take treatment. Why? I told you, it costs money. It's a lot of trouble for them. They don't want to have to see you so frequently, and they'll tell you, yeah, mild MS. And you're like, mild MS? What do you mean? I can barely walk. Your MS is burned out. You don't really need treatment. You're over 50. Don't listen to that. It's nonsense. And in fact, every trial that's ever been done shows it's not true, but people keep trying because they just don't want to do it. But this is what happens. This is your brain disappearing when you're not treated. This is what goes on. All right. So I get a lot of questions about what the best treatment is for MS. There is no best treatment for MS. They're all better or worse in different areas. So there are ones that we use a lot. The drug that just went generic, Copaxone, but everybody agrees, 100% of doctors agree, it's the most safe drug. All right. The interferon beta is pretty safe. Teriflunomide is pretty safe, except for the pregnancy issue. The most effective drugs, there are 3 very effective drugs: Limtrada, Ocrevus, and Tysabri. Tysabri is by far and away the least safe drug we use for MS. It should, in my opinion, only be used for life-threatening MS. It's so unsafe. Ocrevus is the new kid on the block. How it's going to do in the long term, we don't know. We have over 25 years of experience with Limtrada. Limtrada knocks the pants off everything else in the long term. And it stands alone as the best long-term. The best all-around medicine, fingolimod or Gilenya, it does so many good things, and other than the trouble with getting it started, which is kind of complicated to make sure that things don't go wrong, this is the easiest drug to take and the best oral. It is not compatible with getting pregnant easily, so that's the issue with it. As far as fast-acting drugs, these are the fast-acting drugs: interferon beta, fingolimod, or Gilenya, and Ocrevus. These drugs work fast. They get things stabilized quickly. Easy to start. Aubagio is the easiest to start. Tecfidera is the next easiest to start if you can put up with the stomach side effects. And pregnancy-friendly Copaxone, interferon, and Tecfidera are the drugs that are easiest to use around pregnancy. The best long-term drugs, although Lemtrada with pregnancy, as long as you can hold off for 4 months, Lemtrada is fine. And the best long-term data we have from Copaxone, interferon, and Lemtrada. Cancer risks. Cancer is important. Cancer is a bad outcome. And you don't get as much information about that from the government. And it's very inconsistent how drugs are labeled. We know that the injectable medicines which are Copaxone and interferons and teriflunomide have no cancer risks. We know it's very low from Tysabri and Lemtrada. There's moderate risk from Tecfidera, Ocrevus, and mitoxantrone. These are in general, I have my patients all follow if they're on any highly effective medicine, and I left Gilenya off. This Gilenya should be here in low risk area. Gilenya, I left that off that list. But in general, I have all my patients do normal cancer surveillance. Someone over 50 needs to see a dermatologist every year if they have MS anyway. The immune system with MS lets a lot of skin cancers happen. Infection risks, you don't have any infection from Copaxone or interferons. You have low risks of infections with Aubagio. That should say Lemtrada there, not Aubagio, and fingolimod. It's around 1% risk of serious infections a year. And then moderate risk with Ocrevus, high risk with Tysabri and Zenbrita. All right. Let's go to just a few myths I like to talk about. Medicines aren't all the same. I think I've made the point. Some are more effective, some are better tolerated, some work better. The medicine helps a lot even if you're doing well. And people often come to me and say, I think I'm doing well. I don't think I need medicine anymore. And that's when you need it the most if you want to keep doing well. In the long term, they prevent serious impairment. It's like somebody who had a heart attack saying, I don't think I need to take aspirin anymore. I'm doing well. It's the benefit of what's never happens. A healthy lifestyle is very important, but it's not going to fix the MS. MS gets better and worse. So this myth, most people with MS are going to have serious disability. You treat to prevent problems. Only 30 or 50% of people will have a complete response even to aggressive treatment for MS. They'll still all have new problems for the most part. And disabling or life-threatening problems are what are mainly reduced by treatment. One of the amazing things the government won't let Bayer Healthcare tell you is that the people who started Betaseron, which was the first medicine to market, in the first 3 years versus the people who waited 3 years to take it, this is back in the early 90s, late 80s, early 90s, those people were half as likely to be dead 20 years later for starting interferon 3 years earlier. It's that big an effect, and you just can't perceive it in your life. It's enormous, but they're not allowed to tell you that, even though it's a fact. So you shouldn't stop because you're not doing well also, because I guarantee your treatment's working better than you think it is. You need to talk to the doctor to try to sort it out. And if you ever hear somebody tell you your MS is burned out, tell them, I don't think so, because it's BS. So it does not burn out. It does get easier to control, and it does slow down as people get older. I have all these people come back to see me who said, they told me my MS had burned out and I'm not walking very well. And it's like, sorry. Bad advice. This is my other joke. Donate your body to science while you're still alive. Be in a clinical trial. I hope everybody learned something. If you're under 55, no cancer and control health problems. If you're not, sorry, they don't want you. Although there are occasional opportunities. But, measuring yourself, really important, like I said. So I put that measuring yourself thing in the list just so people could copy it down if they wanted that. But I'll stop there and let Stuart tell me, how much time do we have for questions, Stuart?
How long do you want?
All right. If somebody needs to take an urgent bathroom break, we won't go away while you go, I promise.
Yeah, and we can't do an overall stop for bathrooms, okay? Because there's just not enough bathroom, and we don't want to stampede out there. So anyway, Dr. Hunter, thank you for giving us this. And we're going to go with about 30 minutes of Q&A. So again, like I did earlier about the Q&A where I went around both sides of the room. Maybe Jeff, can you give a hand and we'll get a second microphone? Okay, never mind then. All right. So I'm not going to ask him again. It's up to him. But what I want to do is we're going to do about 30, 35 minutes, or if things burn out faster, we'll see. But I doubt it. So we're going to get up here. I'm going to go to this side of the room, and then we'll switch to that side of the room. You got to get a mic from Bill. All right? And
While they're getting the mic set up, I want to say Jeff has a great, one of the videos I've seen that he does that's really great is about spasticity and stretching. And it's really, really important for the people who have spasticity to be extremely aggressive about stretching. It does as much as all the medicines we have, and we have lots of treatments for it. But you will save yourself enormous amounts of pain, disability, and deformity if you follow that guideline that he gave.
Yes, thank you. And by the way, I mentioned something about our YouTube Learning channel earlier. He loves it.
Yeah. Well, my patients love it because not everybody can make it to a meeting like this. And it's a great way. Share it with the people you know. You have MS. When you see these things, people are so much better educated.
Okay, we're going to start here.
Yeah, I know that you said something about I'm sorry, Mike. The words wants to get stuck. Okay. Why can't it be like Okay, Pat and Brenda, I need your help because there's three of us. We're sisters.
Okay. So you're from a family with a lot of people with MS. All right. So here's the situation with that. So about 10% of people with MS have a close family member with MS, and there are families that have a lot of MS, and they are different and break some of the rules that I talked about. Those people have more genes in their family. Usually, you know who they are because there's a man in the family with MS, and when you see that, it's harder for men to get MS. It takes a bigger burden of genes and worse luck because it's the 2X chromosomes that do it to most people. But we don't find when they look at these studies, and lots of studies have been done, that there's any one gene that's more powerful, except for a gene that's really, really common. About 25% of people have it. It's an HLA gene. It's called HLA-B15. And it's a very good gene, obviously, if so many people have it. It does a lot of good. So there isn't like the Joker. You didn't get the Joker or something in the genetic mix. And so you probably came from, both of your parents had a lot of these genes, and you were more at risk, and you guys all got bad luck. But not everybody will. Even identical twins raised together don't usually both get MS. So it's not that strongly genetic. It certainly has genetic risks, though.
Doctor, I've got a twofold question. The first off is there development of kind of like a decoy drug where a decoy element would be placed in the body where the immune system would deflect and go after that versus going after the brain neurological system?
Well, that's a good question. Actually, Copaxone is that kind of drug. Yes, and Copaxone's been around. It's actually been around for over 30 years, even though it didn't get to market first in the United States. It was invented back in the 60s, and it was invented because they were trying to find something that caused MS, and they found something that prevents it in animal model of MS. And it started being used in Israel in the late 70s and early 80s, and it took until 1996 to get it on the market. But it's a drug that we've gained respect for just because it really, when it works, it gets the job done, and it's extremely safe. And what it essentially is a mixture of peptides, which are protein elements, that gum up the ability of the immune system to recognize brain proteins. And it's one of our slower acting medicines. So it works really well for many people at first symptom or early MS. It's harder to see the benefit when people have more active disease. And so we don't usually use it for people with really active disease or long-standing disease. They've usually gone to other medicines. But sometimes we go back to it later, after people still need some treatment, but they've had very aggressive treatment. For some people it works, but that's how it works. It stimulates the immune system to drive to make antibodies rather than to make cells, and it interferes with the activation of the cells.
Okay. And then the other question I had was in regards to data collection. We have the electronics medical system in the States and stuff. Internationally speaking, has a database been developed to track all patients identified with MS, not only with the standard metrics followed by the doctors, but additional lifestyle, environmental, etc., to see if a root cause or several root causes can be identified associated with reducing the onset?
That's a good question. So the epidemiology has been done, and there is no root cause. And what is clear is there's a lot of risks that people have, and the risk factors have been clearly identified for a long time. The first is 100% of people have Epstein-Barr virus. That's not so surprising because it's true of all immune diseases. But it's been proven. It's been proven conclusively, by some really brilliant investigators, because they go and see. They've actually done it in the military. That's how they've been able to prove it, because those people are under really close observation. The other thing that's indisputable is that tobacco makes MS a lot worse. It's a threefold risk of causing it. Why is that? The chemicals in tobacco, the same ones that cause cancer and lung disease, turn on cells very fast. They make the immune system go very strong, very fast. And that's almost certainly the way it does that. Low vitamin D is the thing that happens to do with latitude and fair skin and with genetics. It has all three involved. And people with MS are 10 times as likely to have low vitamin D as the next person, and it's a 10-fold risk factor. Now, some people with MS have fine vitamin D levels. There's other things that are involved, but vitamin D is a very powerful controller of how activated the immune system gets. And people have genes that keep vitamin D low, probably because that was good at some point in time. So those three things are the biggest factors. There is minor affective obesity, especially as a young person. Obesity keeps the immune system turned on, and it stresses the brain. It has a much smaller effect as people get older. And there are hypothetical effects of salt. We're not sure how much of that's real and how much of that's coincidence. But those are the big factors. I mean, there are having a close family member with MS is certainly a risk. It's about a 10-fold risk. Having an identical twin with MS is a 50-fold risk. But MS is not a genetic disease, and it's not caused by any one environmental factor. Stresses certainly can precipitate MS events, but when you look at an MRI scan and you see it, most people have old events on there. It wasn't caused. The disease wasn't caused by the stress. It was just they already had it.
So is there an overall database international databases?
Oh, that's a good question. So there are several databases. We have several large databases. The first one is NARCOMS, which I encourage everybody with MS to go sign up and put your NARCOMS information into. But there are several clinic databases that are very large, but there is no one that includes everybody. There are some countries and some counties where they have everybody. In some of the Nordic countries, they have everybody in a database, like Sweden and Finland and Denmark. And then in Olmsted County, where I lived and trained at one point, they had everybody. Well, that's 200 people. That's not a very big database.
We have the next question here, please. And also, for anybody that's concerned about whether you're going to be on camera or not to ask a question, the answer is simply no. Okay? Those cameras are all facing at Dr. Hunter. Okay? So don't be alarmed. And if you really are afraid, just talk like Mickey Mouse or something. Change your voice.
Okay, I have two questions. One, I read there's a new blood test
Yes.
that was developed here in Nashville.
Yes.
And how accurate and what's your thought on that? And is insurance doesn't cover it? And what about the new treatment, once a year infusion? Is there a new treatment out for MS?
Yes to both, and I'll let me answer the first question about the iQuity test. It's called iQuity with it like iPhone. And the iQuity test was developed by a rheumatologist here in Nashville. And it is an interesting test. How it's going to perform in the real world, we're not sure. And it is not covered by insurance. It costs about $1,500 with the discounts they give you. So it's like about the same as getting your DNA sequenced nowadays. So the iQuity test was designed to look at people who look like they had the beginnings of MS and compare them to other groups of people and to sort them. And the markers that are used in that test, we don't know what they mean. They are markers that were just found by looking at hundreds of thousands of genetic markers that are not how your genes are passed down, they're how your genes function. So they're called RNA markers. They're how the genes work. And this test is very accurate if you look at typical people who come in the door with a first symptom of MS. 95% of them will be positive on that test. It's better than spinal fluid. It's better than MRI. MRI is 80%. Spinal fluid in this area is under 70%. So if it's a typical person, we don't know how it works in the atypical people. And a lot of people come to the doctor very, very early now with MS symptoms. And they may have a normal MRI, they may have very minimal symptoms, all the tests may be normal, but they have pretty characteristic problems, even though they're very mild. We don't know how the test works for that. And the other issue is some people may go to the doctor with a problem that's not MS and they may have MS. They may go to the doctor because they have migraine and they have MS too and they don't know it. We don't know how it performs in those people. So is it worth doing it? If it's already clear you have MS, there's really no advantage to the test. We may have a way to use it someday, but it doesn't tell us anything about how people are going to do, other than the fact that it reliably discriminates people who are probably going to have another problem in the next couple of years. We already standardly treat those people like they have MS. We don't call with this old term. We used to call things optic neuritis, myelitis, demyelinating disease. We still use those figures, but it's all called early MS now. It's part of the relapsing MS spectrum. So people, first symptom, you can't call it a relapse because it hasn't happened before. It's called first symptom. But then after that, people are called early MS. And then the next symptom is a relapse and then so forth. But people are called relapsing MS until they haven't had relapses forever. And then they just purely have progressive sorts of symptoms. But relapses can be a long time in between, and people don't usually get better from all their relapses. So it's not progressive disease. If they've changed, if somebody can say, yeah, I changed last year, that's a relapse. That's not a progressive disease. So we have no test that tells us who's some kind of phenotype. These terms, relapsing, progressive, primary progressive, they don't mean that much. They're anachronistic or outdated terms. They're descriptions. And the underlying disease, people have MS if they have things changing over time and evidence of that. And we actually have data that treating people who have abnormal MRIs at their first symptom, you're far better off getting treated than you are waiting to see something change. So that's how we are. So where the equity test fits in, we don't know. Your other question was about a once-a-year medicine. We not only have a once-a-year medicine, we have a medicine that's 2 years, and then most people don't have to be treated again for MS for a long time. That medicine's called Limtrada. It was previously called Campath. It's been around for 25 years. 2 Nobel Prizes were handed out for the medicine back in the 80s. Because it's a very old drug, and it was tested, and it took a very long time to get it approved in the United States because of our government. There was a bad actor in the government who slowed it down for a long time. But this medicine is approved in the United States for people generally who've tried at least 2 other medicines. It was tested in people who had relapsing MS, who hadn't had MS forever or hadn't had MS so long that it was not thought to be useful to treat them. And it works very well. And the government won't let the company tell you that most people get better, they improve. A third of the people improve dramatically. And they also won't let them tell you that it stops your brain shrinking completely, by the second year. It's an amazing medicine, and it's hard to use, and a doctor has to be certified to use it before they're allowed to use it. But it takes 5 days in the infusion suite the first year, 3 days the second year, and then you don't routinely get other MS treatment. You just get, if you have a relapse, you can get steroids. And it cleans out the immune system, and it lets it rebuild. And the rebuilding is important as in cleaning it out. And it takes years for the immune system to rebuild. Many people get better, keep getting better. But in practice, I would say 75% of people are better off 5 years down the road. 25% are worse, but those 25% had really difficult MS. And almost everybody says they were glad they did it. But it's a very slow onset of effect over a couple years. All right.
Hello, Dr. Hunter. Question, what are your thoughts when you are seeing a patient for the first time, perhaps that was just newly diagnosed and they're trying to navigate what their treatment should be, as far as giving them a long-term prognosis as to what their potential disabilities would be? What are your thoughts about communicating that?
Well, first of all, treatment has a big effect. People don't appreciate that. The thing that when you look at research has the most effect is people get treated at first symptom. And the second most important thing is that people don't use tobacco. Those 2 things have more effect on people's outcomes than anything else. As far as telling who's going to do better than everybody else, women who have mainly sensory symptoms and optic neuritis do better than everybody else because those are smaller amounts of damage in the nervous system. People who have trouble with their legs or their brainstem functions early do worse than everybody else. People over 40 are usually quite impaired at the time of diagnosis because the brain doesn't put up with the damage. And people who don't recover from their second relapse well usually are going to do very badly. That's just an armchair sort of way to look at that. In terms of prognosis, the prognosis has been getting better for the last 20 years, and the age at which they need a cane to walk has been going backwards by about 5 years every decade. So it's getting better and better. Our treatments work. They work really well, even if they don't completely control the disease in terms of protecting people. And like I said, the biggest benefit, getting treated the first 3 years makes a 50% difference in who's dead 20 years later. All these treatments work very well. Some work better than others, though.
Next question is here.
Hello. First of all, I was wondering, is there anything that is considered a really complete type of diary system that is put out by anybody that tells your emotional, physical, and everything as far as to keep a log that you do take to the doctor?
That's a very good question. Stuart actually has some good ones. Yeah, you can go on his website. But there is not a widely accepted comprehensive one. There are some questionnaires we use sometimes. The problem is they're all copyrighted, and so it's hard to disseminate that information. But your doctor usually has some kind of questionnaire he asks you a lot of questions about. We use that, but there's always so much to talk about at a visit. We usually go from whatever the biggest issues are right now, what we did at the last visit, what we were dealing with, and what's the biggest problem you have now. But I wish there was. There are sleepiness scales that if you have a fatigue or a sleepy problem, I recommend you use the sleepiness scale. There are mood screening scales if you have depression. But those, if you have a depression problem that bad, I recommend people see a psychiatrist because they're going to be much better at treating it than a neurologist will.
Yes, I was treated very young for psychiatric and mood swings, et cetera, and then that was when I was in 24, and I've still been treated for that. Now that I have MS since 2008, it has been very confusing for both doctors to even figure out what was real and what wasn't.
Well, the answer is that depression and MS are both syndromes. They're not diseases in the say. They're a constellation of symptoms that people have because of disease. And there's been some evidence in recent years that depression is in part due to inflammation in the brain too, especially severe depression. But the association of MS with bipolar disorder goes back 50 years. I mean, I've seen articles that are 50 years old talking about that. The majority of MS patients will get depressed at some point. The problem with fatigue and energy and concentration, they're on all the depression scales. People with MS look depressed when you test them for depression. I actually published a paper on Gilenya improving depression, and it does not an antidepressant. It is an anti-inflammatory medicine. Does all these good things for the brain, but people's depression gets less. We don't understand that. And interferon beta, which I love and controls MS really well, although it's hard to take, it sometimes makes people more depressed. But most of our MS medicines don't affect it one way or the other directly. But the better your MS gets, the less of a problem people usually have with depression. Great. Got another.
Hi, I've had the Lemtrada treatment, and as you know, I have a lot of lab work. So my question is, how do you talk to your doctor? Because some of my lab results, they come back normal, and I just get a letter in the mail that says your results are normal. But I feel like sometimes I'm like on the low side of normal. So how do you talk to your doctor about what's normal for you and what things you should be worried about? And
for lab tests or for what?
For the lab results that you get.
Let's talk about the lab tests. So Lemtrada is this medicine I was just talking to our guest about. That's the medicine that cleans out the immune system, and the immune system rebuilds itself. And there are some safety tests that are done on a regular basis that, because the immune system occasionally will have a problem as it rebuilds with causing a bleeding disorder or much rarer kinds of problems. And you can see that coming on blood tests. So these blood tests are done regularly. In most cases, everybody's an individual as to how long the immune system comes back. And these tests are done purely on the chance that about half the time you see the problem before people ever notice it. And these problems occur to 1% or less of people. So we most commonly, when you're doing a urine test on people every month, you're going to see somebody with MS get a bladder infection. So we just call them up and we say, you got a bladder infection, you need to get it treated. And we hope it's not that time of month at the time they go do the urine test, because we say make sure you don't get it done when you've got your menstrual flow, because it makes the test abnormal and it just confuses everybody. But what's normal for someone with their lymphocyte count, which is what comes back gradually is completely individual. And there are averages, and there are people who are fast, real fast, who it hardly looks like it goes down at all. And there are people who are real slow, where we actually look and we say, why don't we hold off on giving people the second course? It's not very many, but we're obviously in no hurry because the immune system hadn't even gotten back up to where we would consider it a good idea to treat it. But there's no textbook on how to do this. So as long as things are safe, we're okay. We just hang out and watch it. It's not a problem. It's not a big. We treat everybody who gets Lemtrada for a couple years at least with a medicine that prevents cold sores and shingles, which are one of the more problematic infections that occur early on. And since we've been doing that, nobody gets them. So it's a very simple thing, and I will usually continue that till somebody has a pretty good complement of lymphocytes, which is getting towards the normal range. Yeah.
Can we get a copy of your presentation too? One other quick question.
I'll post it on our Facebook, which is Advanced Neurosciences. I a link to it somehow, and. It'll be on the video if you want to see it too, but I'll put it up on the Advanced Neurosciences Facebook page.
I'm jumping on the Lemtrada question, 2 parts. How does Lemtrada differ from stem cell replacement therapy? And if someone had to choose between Lemtrada and Ocrevus, how would they make that decision?
Okay, and if you don't remember what I say, go look at my Facebook page. But let me summarize these 2 questions. The first is about stem cells. Stem cells is a big subject. Anybody who's advertising to you about stem cells online is a quack. Don't listen to them. Don't talk to them. Don't contact them. All right. They're dangerous. The government has tried to shut them down, keeps trying, because they are legitimately dangerous people who are after your money. All right. MS gets better and worse. If you happen to get better after a stem cell therapy, you were really lucky, and we've had plenty of people that were nearly killed by these folks. Don't listen to them. All right. What is legitimate studies that use stem cells are people who get high dose chemotherapy and then get stem cells because they will die from the chemotherapy if they do not get their own stem cells back. All right. That's called autologous hematopoietic stem cell therapy. And that is an established treatment that was developed for cancer and has been used to treat people with MS inside of research trials and rarely other people. It is effective. It is very dangerous. It is our most dangerous MS treatment. 5 to 10% of people may die when they get that treatment. We don't use it for MS. It would be reasonable to use for some people if they ever get it safe. But the fact is, we have drugs that are just as effective or more that are very safe, that we know how to use and are accessible. All right. So there are other kinds of legitimate stem cell research that's gone on. The research that's been done that resembles what's done in these clinics who advertise you on Facebook and tell you, send you videos of people who say they're all better now with MS. The science that's been done with them shows that nothing happens with the MS. All right. They're small studies. There will be more. We'll get better answers. But when it's done properly, it's probably safe. But it looks like it doesn't do anything. So don't waste your time with it, is my advice. Now, the question about Ocrevus and Lemtrada. Let me tell you about Ocrevus and Lemtrada. Ocrevus is a drug that's identical to a drug that we've had for many years called Rituxan. And it is a better engineered, more human-like molecule than Rituxan. But it essentially does the same thing. And it's been studied much more for MS than Rituxan was. And it was studied very well with some of the best research studies that have ever been done in MS were done with Ocrevus. And about the only downside to Ocrevus is we don't know enough about how it affects people who have a lot of treatment experience and MS therapy in the long term, because people with weak immune systems were kept out of the studies. for people who are fairly new to MS, who have very aggressive MS, it would certainly be a reasonable treatment. And several of the insurers have just put it into a third-line position because they've recognized these issues. It's an effective medicine, and like all effective medicines, you have to look at what the risks and benefits are. And the benefits are it works pretty quick and it works pretty well. And so if somebody needs a really quick solution and that's one available to them, that's an option. The people it's not good for in my book are people, when we look at their immune system's weak. They're taking more risks. Now, everybody who has immune system's taking risks, but it still may be a good thing to try for them. The long-term data that we have for that is incomplete. We don't know enough about how long to use it, what we will do, how we get out of it, or what problems come up down the road. We know the cancer risk is not trivial, but it's not dramatic either. So people need to have their normal cancer surveillance with Ocrevus. With Lemtrada actually got labeled for cancer, but the cancer risk is so far below 1%, it's a joke that it has a cancer risk on there. Now, Lemtrada is a lot more work to get done, and it's slower. It's really well into the second year before people really feel like it's working, although statistically it works pretty well because there are a lot of people that get immediate responses, but people who are really sick may see quite a delay in response. But the thing is with that medicine is it keeps getting better. And when you just do research, when the company just is allowed to show you research for 2 years, it doesn't show you the really long-term data. But all these companies, you have to get the long-term data from your doctor or from the literature directly, because the government won't let you see the real data. They prevent the company from showing it to you. And it's a real shame because people with MS are smart and they want the information and the doctors want the information, and FDA makes it very hard for them to get it. And they will actually punish the manufacturer financially, unbelievably, if they let this out, so yes.
You've talked about early intervention with medicines on MS. And I think we're generally talking about relapsing remitting. I have primary progressive, and Ocrevus was just approved.
Yes.
So I don't know if there's a difference in the brain degeneration that you're showing over time and that slows down with the early intervention. And if you have primary progressive and a medicine was just approved, is there a difference in that progression? Or
Well,
you said a
that's
few
a good
minutes
question.
ago that MS, they seem to kind of run together. There are not that many differences. So then why are there so many differences in the medicines that are offered for relapsing remitting versus the
So back in the 1990s, the U.S. government decided that they were going to treat people with progressive components to MS differently and require different tests than people with predominantly relapsing components. And they forced all the research to be done with a scale that is not sensitive to getting worse in people with progressive disease. And even though all MS medicines worked on MRI abnormalities and relapses for those people, and people with progressive disease do still have relapses, whether they didn't have them in the beginning or they did, they still get them. In fact, if you follow them for 3 years, in one study, nearly half of the people who had said they never had a relapse, their doctor said they never had a relapse, were observed to have a relapse. So we know that progressive MS is a description, not a disease. It's a description of what's happened to people. But as such, because they made it a definition, the government made people test it in a different way, and they used testing that wasn't as sensitive. So what they've started doing is testing people who are younger and sicker when they do these studies. And they were very successful when they did this, but just 10% of people difference in getting worse drove the whole effect that the drug worked. All right, because once somebody has bad legs, the odds are they're going to keep getting worse for a while, even if they're treated. Some of those people will level out afterwards. So it's not a different disease. It's a different manifestation of the disease. And so primary progressive MS means someone was never observed to have a well-defined onset of a symptom or a relapse. And when we see, and we tried, the company came to us and said, we want to give this medicine to everybody with primary progressive MS before they come to market. And we said, we'll do that. And we saw their thing, and they said they must never have had a relapse. That did away with about 50% of them, because these people have relapses. And then they had to be young. They couldn't be on any strong medicines for the immune system. They had to have a very strong immune system. We could find very few people who met that definition. It was a very well-defined group of people they tested in. There were people who were sick, getting worse, had really good immune systems. And when they did that, the medicine worked. And so Ocrevus certainly works, and it's certainly a strong medicine for those people. But Copaxone, if you look at their data, Copaxone worked too. It just didn't work well enough for the government to approve it. And statistically, it was a weaker effect. But it worked. We think everything probably works, but we can't prove that. And pharmaceutical companies aren't allowed to market things that the government doesn't say. If they came out and said, well, we tested that medicine and it worked really well on the MRIs, they'd get $1 billion fine. The Department of Justice would show up and say, we're going to shut you down, or you're going to pay us $1 billion. So you don't get that information. But Ocrevus is a good medicine for primary progressive MS. I would treat people in a minute with it. And I do, and it's a good way to get it under control. How well does it work 5 years down the road? We don't have that data yet. We'd like to have that data. We'll get it in 5 years. Yeah, sorry. All right, I'm sorry. I thought maybe I made a mistake. Stuart was giving his.
My voice spoke before my brain was ready.
He was giving me his New York intervention there. Yeah. Yes.
No. Wait.
Okay.
Sorry.
Who's next?
He's next. Then we have one back here,
okay.
And then we could get over there.
All right. I'll follow instructions better.
Okay. I just want to ask. Well, I have a million questions, but I'm only going to ask two. Is MS being described as a traumatic brain injury?
Well, it's not due to the kind of head injury that we normally mean when we talk about traumatic brain injury. It does affect the nerve cells like that, and there's a lot of microscopic effects. People who have a really bad hit on the head and are like in a coma for a week, when you do their MRI scans, you can't even see much of the effect. It's microscopic. And that pressure wave does the damage. With MS, it's the immune system doing the damage, both directly and indirectly. And so it's a pretty different kind of problem, but they both involve inflammation. There are different types of inflammation, and it's more a diffuse kind of inflammation. So people with traumatic brain injury, this problem with the microscopic I showed you, where the dendritic spines, the connections between nerve cells, they disappear in that, and they have to be rebuilt. That's why those people get better, but it takes a long time. It takes like a year. For them to get to where they're going, sometimes longer, but that's the same sort of condition.
Okay, and this young man right here, now he kind of inspired me to work out more, so I'm going to do that. So, but the reason I don't take any of these medicines is because of the fact that, first of all, I need to know basically how did they make it up. If they can't tell me how MS got started, then I feel like, how can a chemist just make something and give it to a rat and say, oh, it stopped a rat, so it could help a human being? So that's why I'm.
Well, I guarantee you that thousands of people served as rats before it was ever sold or marketed for that purpose. But the thing is with high blood pressure and diabetes and Alzheimer's disease and high cholesterol, we don't know exactly how all those things happen either, and we stumble into every every advance that we make in medicine, and things go. In some of the MS medicines, we know exactly what they do. They were designed to do that, and some of them we only figured that out by chance. And so it's not such a troubling thing that we have a hard time pointing at that. But again, this issue of there's censorship by the government. The government doesn't let these companies tell you how they work. They let them tell you what the government says. That's all. And so there's a lot more information out there, that a doctor or a public forum like this could share about you with how things work. And people always ask me, I get this question about how does Lemtrada work a lot. Well, I say it's a lot like going and scalping your yard. It cuts all the grass back and the weeds, and when the grass comes back, the weeds aren't there anymore. And people ask me about other medicines like Ocrevus and say, how does it work? I say it sits on the cells that are coming out of the brain that are telling it to keep going. It knocks them out, and it knocks down that end of the immune system, which is what keeps things going. We understand that for a lot of our medicines, how it does, and some of them better than others. But it's really, it's way more information than what we had in the 1900s when they used to think your blood was too hot, so we should drain some of it out of you.
All right, next one. Nita. Tell us about Nita.
Nita.
No evidence.
I knew her well.
Yes.
We had a great time.
Yes.
Yeah.
So like my fortunate circumstance, tell the rest of the people about
Nita means no evidence of disease activity. People from the Latin countries like to call it nada. But here's the thing: it depends on how good your glasses are, essentially, as to whether you have no evidence of disease activity. It depends on how good your MRI is, how good your neurologist is, how good you are. Because everybody essentially is going to change some. So no evidence of disease activity means nothing changed. And actually, in research trials, this is a really stringent criteria because they measure MRIs to the 10th of a millimeter. And so most people change. And so it's not a realistic way. And so we've started talking about META, which we mean minimal evidence of disease activity. So if someone has a new MS lesion, we think, oh, that's bad. But if it's 3 millimeters, it's like, who cares, okay? If it's 8 millimeters, well, that's about 50 times as big a lesion by volume as a 3 millimeter lesion. So it's a very big deal. If it's a black hole, it's even bigger deal. So it depends on what we're talking about when we talk about disease activity. So it's a constellation of things. And my Canadian colleagues came up with 3 gauges: relapse, MRI, and disability. And we're far more worried in medicine about somebody who's lost ability to do something than we are about tiny MRI changes. But if people have MRI changes on treatment, it concerns us because it means it's not completely controlled. Now, the first year people are on a treatment, doesn't really matter much. It takes time for a lot of treatments to get working. The way we do MRIs, it may, the first MRI may have been 6 months before somebody went on treatment. So something could have gotten worse in there. But we don't want to see something new or really active on an MRI. We move very quickly between therapies. And there's essentially 3 tiers of MS therapy. There's the first line medicines, which are interferons, Copaxone, and Aubagio. And there's a second line, which is really Gilenya and Tecfidera. They're stronger medicines. And then there's a third line treatment, which is Lemtrada, Ocrevus, and Tysabri, which are really powerful medicines. And other kinds of chemotherapy approaches, when they're used, we don't use those very much. But those are, in terms of how much impairment it does to your immune system, in terms of how much risk you might be taking them, or something could go wrong, that's kind of the same tiers. We do it that way. So everybody's different, and somebody who's clearly not doing well, we look at changing their treatment. There are some people that, we have to live with a certain amount of disease activity. But minimal evidence of disease activity is the goal, and we get that with a lot of people now.
Can you talk some about CBD oil and medical marijuana?
Sure. Okay. People who have certain symptoms that are very hard to make better sometimes benefit from medicines that are called cannabinoids. Cannabinoids come from cannabis. That's where they're from. And marijuana is cannabis that has a high content of one psychotropic or psychoactive chemical called THC. That's what makes people high. And it has other components that are not in that family of psychoactive, and one of these is cannabidiol, and that's CBD. That's what CBD is. In Europe and Canada, there's a drug that's approved for MS called Sativex, which has a 1-to-1 of these two elements, and it's approved for people a little differently from place to place. It's actually approved for people with cancer too, for intractable pain. It's an oral spray that's basically dosed very gradually up to the dose to decrease the symptoms of spasticity and pain. It doesn't actually change the objective very much, but people say it makes them feel better. And so we have data that this works. Now, in the US, we don't have access to that product, but we have two other kinds of products. In some states, marijuana is legalized in one form or the other, and smoking marijuana is very bad for your mind, and it's very bad for your lungs. But it's a free country, and if you want to do it, just don't keep a gun with your marijuana or a lot of it around, because you will go to jail and they will call you a drug dealer. So, but if you do it, you've got a lot of company, but that won't help you if the law is not on your side. So there are, these medicines, people use them because it makes them feel better, but they have side effects like any other medicine. And people who use a lot of marijuana, real marijuana, not the CBD oil, it affects their thinking. You can see on any testing that these people have much more impaired thinking than the people who don't. So it's a trade-off. You have to trade it off. And when THC was actually tested in Britain for MS, and it does help the MS, but it makes about 20% of MS patients go absolutely nuts at the doses it do. So it's like any other thing in medicine. There are risks and benefits, and you've got to choose carefully and don't get yourself arrested doing it. As far as CBD oil goes, CBD oil is made from hemp, which is cannabis, which is not marijuana that people smoke. It doesn't do anything for you. It doesn't have a lot of THC in it. That was bred into it. And CBD oil is very safe. It's basically many people say it helps their pain. Many people say it helps their anxiety. There's not enough research to know exactly how much you do, but the Sativex, what I can get from the Sativex data is that it's pretty similar to what people are doing with Sativex, so which is approved everywhere else. And when they tried to get it approved here, the FDA said, go away. And if you get the idea that I'm not always happy with how our government does things, so it's because of FDA. It's they told them, go away. We don't want to test this. We don't want this to be sold in the U.S. And it's a shame because it's a medicine that has a role in the rest of the world, and we don't have it here. Yes.
Yes, you were talking about the three tiers of medication.
3 tiers. Yeah.
Okay. My question to you is that if somebody has reached the third tier, I've heard a lot of comments that say that they're fearful if that doesn't work because there's nothing else out there for them. There's this assumption that once you hit that third tier, you can't go back to the second tier.
Oh, sure you can.
Yeah.
So that's a good question. Well, let me tell you, this issue has only arisen because we have a really powerful medicine that fixes things called Lemtrada. Maybe Ocrevus will turn out to work the same way. We don't know yet. But Lemtrada fixes the immune system so well that things start working that didn't work well before. And as people get older, as they get older, we have the problem that their immune system is getting older too, and they get more at risk for infections. And we get very concerned about knocking the immune system down too much. If somebody is so desperate off with MS and they're trying to get quality of life in a few years, and they're bedbound or quadriplegic, and they're trying to live their life and enjoy their family, that person's going to die from pneumonia. They're not going to die from some other rare complication or from their MS. And what's my best strategy for that? I put them on Tysabri. Why? Tysabri is a very risky medicine. But look, this person's going to die from their MS in the next few years because of complications from pneumonia, because they're not swallowing well. They aren't going to want to go on a ventilator when they get pneumonia, and they will, and they're going to die because they can't go on a ventilator or don't want to, or the family doesn't want them to, or something. Tysabri is not going to cause pneumonia. Ocrevus and Lemtrada are going to put them more at risk for pneumonia, so I'm going to use Tysabri. So the situation's different. And where I might say to everybody else, you shouldn't take Tysabri, if they have life-threatening MS, I don't have a problem using Tysabri. It's fine. If they get PML, it's like, well, that's really bad luck, because they were going to die of MS anyway. But it's horrible. But most people, we're not talking about life-threatening MS. And so to use stronger and stronger medicines that put people at risk, we want to see that they need it. We want to see that they need it. The right medicine might be to start over and go back to Copaxone. And Copaxone is a very safe medicine. It doesn't interact with any medicines. It never causes a life-threatening problem, and we do that sometimes. And then if we see they're not doing well enough on that, then we may go back to another oral, or we may go to a different IV medicine like Ocrevus. But we want to see people's immune system is safe enough to do it, and that's my approach. That's not something you'll see in a textbook or hear from every doctor. But you have to be thoughtful about this because we have so many different medicines. But there isn't a right way. It's the seat of your pants sometimes in figuring out what works. And the MS does back off a little bit as people get older. It gets easier to control.
One last question from this
sir.
gentleman. Second to last question. I got it.
I'm sorry.
One question.
I know.
Okay, I'm holding it.
Okay. You got it? Okay. Sir, just a quick question. I understand your feelings on the FDA and all that, and appreciate the, the censorship on data and information. What my question is what would you suggest are some sources that patients, caregivers, and all can go to find this information in other countries, other organizations, and so on and so forth? Sure.
Well, the MS Society and the affiliated organizations that are part of the MS Coalition actually put a lot out there. MS Association. There's a lot of private physicians who do it. I do it. Dr. Boster does it. There's Dr. Giovannoni in Britain who publishes a lot of information, who's at the Bart's MS Center. There's a lot of good thinking and things, and we all have different perspectives. We all have different biases, and you'll see those in what we put out. But the thing that I think is the biggest resource for MS patients, they have a care team who is interested in working with them and figuring out what's best for the individual, because there's no one-size-fits-all treatment for MS. We might have that someday. The insurance companies are going to force everybody to take Copaxone if you haven't taken it yet. I hope you've taken it already and it won't get in the way of whatever treatment you need right now. But we've seen that coming for a number of years. But there isn't... The problem is anything that involves a company, they cannot say anything that is different from what is in that published prescribing information that the government approved. If they do that, they will get $1 billion fine or be shut down. It is that vicious a system, and it's just as bad as why people with MS who have Medicare or TRICARE can't get assistance directly from a pharmaceutical company. Why? Because the Department of Justice will shut them down because they consider it a violation of law, a kickback. They consider it a kickback. So maybe that'll change someday. But it's good information. Stuart, great information, lots of information. But to research a question, if you have a particular question, the only way you're going to be able to get it answered is by asking. And many times you may be able to get a doctor in a public forum to answer that question if it's by a pharmaceutical company. If you specifically ask it in a way that lets him respond. Sometimes they're allowed to respond to the questions. They're just not allowed to talk about it unless somebody asks.
Thank you, Dr.
All
Hunter.
right, thank you so much.
Thank you. We could do Q&As all day, and we have done this in certain locations. Fortunately, though, this is our first program in Nashville. We will be back again in May. The Consortium of Multiple Sclerosis Centers will be doing their conference this year in Nashville. And since we do programs every night, the night prior to every CMSC conference, usually in other cities. Again, this year it's coming, in 2018, it's coming here. We will be doing a program here in Nashville, possibly even this location. We'll see about that in the coming months. But for that program that we're going to be doing, it's going to be a roundtable discussion. It's going to be topics that we're giving to 3 neurologists to talk with each other about. One of the neurologists is Dr. Hunter. Another one is Dr. Aaron Boster from Ohio. If any of you have heard him, and if you haven't heard him, you could go to our YouTube channel and you could watch what he's done for us in the past as well. And the third one is a very dear friend of Dr. Hunter's. His name is Dr. Daniel Cantor. And the 3 of them are going to be fabulous. Now, it's not just for the local community, though, because we're going to live stream this event. So we're going to bring the nation in on this one, all right? But the best way, though, for you to be there to get your questions answered is to actually be in attendance. We will be giving out a phone number for people that are, want to ask questions from around the country, but we're going to be mainly taking the questions from the audience that's there, on hand in the location, like I said, possibly this arena. Again, we'll be putting out information about that. The planning is already underway. The grants have already been applied for. We will be doing this. Jeff will also be back at that one as well. He's going to do something a little bit different. I don't know yet. I might have to roll him on the floor or something, but we'll find something for him to do. Maybe Julie will be back again. Maybe she'll come out here and sing to you all for a few minutes at the beginning of the program. We'll have to see. And, we're just going to go forward with this. So, again, this is our first time in Nashville. It's my first time in Nashville. I can't wait to come back again. You guys have a beautiful city. You guys are beautiful people. I love speaking to all the people I met on the streets. And again, I just want to thank you all for coming. I want to thank Sanofi and Biogen for providing us the grant to do this program. Jill is reminding me that you have to fill out the seminar evaluation forms. Again, we want to thank Jeff for doing what he did. If you all want to give him a round of applause, that's great. Julie, we've never had a patient advocate speak at any of our programs. She is my first. I can't wait to use her again for another program, and I can't wait to see her book when it comes out. And, as soon as they have it published, I'm going to know about it, and then the world's going to know about it because we're going to make sure it gets out there. We have over 70,000 people that follow us on the different social media channels, and our YouTube channel, like I said, over 150,000 views last year. There are a lot of people that are watching what this little patient advocacy organization is doing. And why? Because it helps that we have MS, and we're bringing it back out to you as well. So again, I want to thank everybody for coming. Dr. Hunter, awesome. Thank you for everything. You all have a great day. Make sure you drive carefully.